So we continue to train folks based on recent expansion needs in our field. And it's unclear if we are training too many people.
Welcome back to Pediatric. I'm Zach Hodges.
And I'm Alice Shanklin.
And today we're only discussing the state of the future pediatric intensive care physician workforce in the United States.
Yes, super chill topic. And to talk about this with us today, we have Dr. Chris Horvat. If you've searched for a common pediatric disease in PubMed, I don't need to tell you who Chris Horvat is. Dr. Horvat is a pediatric intensivist and informatician at UPMC Children's Hospital of Pittsburgh. He started his academic career at UNC-Chapel Hill, where he got his undergraduate and medical degrees. After this, he did his pediatric residency at Seattle Children's and pediatric critical care fellowship at UPMC. He took full advantage of being in Pittsburgh. He did their T32 Postdoctoral Research Fellowship in Pediatric Neurointensive Care through the Safar Center, earned a master's in health administration from the University of Pittsburgh, did all the things. He continued as an early career attending at Pittsburgh. He now has an active K-23 Career Development Award and serves as a clinical informatics leader, helping to deploy randomized, embedded, multifactorial adaptive platforms or REMAP trials across the UPMC system.
Yes, we're so thankful for him joining us today. After listening to this audio, you may find the conversation to be somewhat melancholy, but I think it's an important discussion because a lot of the graduating fellows going through the job search is probably feeling some of the things that we discussed today.
Yes, but Zach, I just want to highlight we had a great time interviewing for attending jobs.
We sure did. It's so much fun to meet people, either all around the United States, all around the world, or all around the region that you're thinking you'll move to.
Yes, this is a global conversation that's a little bit negative, but we didn't actually feel that way while it was happening to us.
Yes. Let's get right to our conversation with Dr. Chris Horvat. Welcome back to PedsCrit. We are so excited today to be sitting down with Dr. Chris Horvat to talk about this really important topic. Chris, will you tell the audience a little bit about yourself and include something you enjoy outside of medicine?
Sure. Well, first of all, thanks again so much for having me here. Honored and excited. I guess a little bit about myself. I just wrapped up my 10th year here in Pittsburgh, working at UPMC Children's Hospital. Each year has been a privilege to be here, but I'm originally from Canada. My father worked in mining for essentially his entire career. We moved around the Eastern North America to different mining communities growing up. I was born in the uranium mining community in Northern Ontario, but I spent my largest chunk of childhood in Western North Carolina, where my father ran a high-purity quartz mine. And most people don't realize, but those mines in that small Appalachian community are actually the world's only current source for the high-grade silica that are needed to manufacture microchips. And so I actually worked for the mines when I was in high school. And when I was 17, I was an MSHA certified miner. So I like to lay claim, and I can't guarantee the accuracy of this, but I like to lay claim that I'm probably the only clinical informatician that has developed electronic workflows truly from soup to nut. Because at one point I was
awesome.
even mining the raw materials that are now powering our advanced computational capabilities in medicine. And since you asked about my interests outside of medicine, really what time is left is all about my family. Anytime I can get in the outdoors is great. Usually hacking my way through some do-it-yourself project at home.
Well, that is awesome. How did you become interested in clinical informatics and then taking it from there to really the clinical decision support?
I can't really pinpoint, honestly, how I ended up here. Though it is safe to say that there was always a natural draw for me to this space, much in the same way as I might describe that I was tugged by powers beyond my control into the space of pediatric critical care. If I had to define the route more precisely, I would say that it's the inefficiencies and irrationality of the way that we provide everyday care that really eats at me. We do many amazing things in medicine, but at the end of the day, I really think we could do so many things better. And at the core, I think, of our inefficiencies and lack of adherence to fundamental best practices is our inability to seamlessly and efficiently access and transfer information. And certainly, in our modern world, technology plays a big role in lowering the barriers to efficient and effective information exchange. But I would say what really drew me to informatics is its foundational purpose is actually to improve the availability and transfer of high quality information. And technology is just one means for accomplishing that primary objective.
And as a critical care trainee, when I think about informatics, if someone asked me to define that, I'd probably give them a really hand-wavy explanation. And how to get into that is somewhat of a black box for me. Do you have any advice for an early career critical care fellow or early career attending who wants to explore clinical or research informatics? How would you get plugged into that?
Thanks for asking that. I guess the first thing I would say is that this is an incredibly exciting space to be in. And we have the fortune now of really standing on the shoulders of some giants in this space who have helped to lay brick along the path that we're walking on. The notion of using clinical decision support and developing health information systems using computers has been around for eons. There were pioneers like Clem McDonald, Marion Ball, Alan Morris, to name only a few, who were doing this work long before it became the standard for delivering healthcare, and well before you could label it as being cool, I would say. And so I think for people who are looking in this direction as a potential career trajectory, we can confidently call ourselves the architects and engineers of modern healthcare delivery at this point. In the past several years, our data sources have started to become much cleaner. We're much better educated about what works and what doesn't in electronic workflows. And the rest of the world is really starting to pay attention to clinical informatics as a guiding force to steer healthcare overall into a better direction. And we've also obviously observed some monumental breakthroughs in decision support for everyday life recently with the advent of large language models. And we're only beginning to scratch the surface of the potential of those in the delivery of healthcare. With all of that in mind, I'd say it's essential for people looking at this as a career opportunity to recognize that clinical informatics is a big space, and increasingly formal training is absolutely necessary to navigate the environment with confidence. I have an MHA that I earned during my T32 fellowship, which covered a lot of relevant ground because so much of that is about how you administer the systems that deliver healthcare, and information transition or transactions, pretty much the biggest part of that. And by way of just my practical experience, I was able to sit for board certification through the American Board of Preventative Medicine. But in time, I've also supplemented really heavily with formal coursework in information technology and systems from Carnegie Mellon University here in Pittsburgh, and actually am more than halfway through a second master's in information technology, just because of the need to become really adept in some of the foundational skills that are necessary to navigate this space. So if I were approaching this space now, I would absolutely consider pursuing a formal fellowship in clinical informatics, like the one we recently opened here at UPMC. And I would say that anyone who's interested in this space can also feel free to reach out to me individually with my email, and I can tell you more about the fellowship here, and I'm happy to share my experience personally as well navigating a career path in this arena.
Fantastic. Now, Zach and I might be the ones with conflicts of interest in this episode because we're graduating third-year fellows at the time of recording. But before we get started, do you have any conflicts of interest related to today's topic that you need to disclose?
No, I do not.
That sounds great.
So this winter, the Journal of Pediatrics, Volume 153, Issue Supplement Number 2, published in February 2024 and linked in our show notes, is an entire issue dedicated to the pediatric subspecialty workforce. Broadly, what were the goals of this issue? What can people sort of open it up and expect to read?
Well, I guess by way of a little bit of background, gave rise to this issue. Those of us who work in pediatrics, whether it be primary care or a subspecialty, can appreciate that our patient population has evolved alongside the capabilities of medicine and the ever-changing characteristics of our society. And broadly, as Laura Leslie outlines with her co-authors in the opening manuscript to the supplemental issue, there are three domains that impact heavily on how we're able to deliver care for children. One, the needs of our patients. Two, the reimbursement market, including both patients' and payers' ability and desire to pay for certain services. And three, the supply of capable physicians to meet the needs of patients in that context of the market and the related systems of care. In recent years, we've observed just how tenuously positioned we are in the United States healthcare system for meeting the needs of sick kids who require specialized care. Community pediatric wards have been shuttered. Many pediatric subspecialties are underfilling training spots. And as a result, there's a growing concern that kids are suffering. For example, there's been a lot of coverage recently highlighting that children who present to an emergency department that is less prepared to care for acutely ill pediatric patients are more likely to die. Additionally, times of strain, such as the recent triple-demic, which was that surge of respiratory viruses, influenza, COVID-19, and respiratory syncytial virus, have demonstrated some substantial cracks in the foundation of pediatric healthcare delivery in the United States. And we know that a healthy supply of pediatric subspecialists is necessary to meet the growing demands of our increasingly complex patients, but it's unclear whether individual subspecialty fields are on a trajectory that will meet those needs. So the purpose of this collection of manuscripts in the supplemental issue of Pediatrics, when there's one manuscript for each of the 15 subspecialties, was to project the supply of pediatric subspecialists using a model based on current historic workforce data in order to provide essential information to both individual level decisions related to things like choices in subspecialty career, as well as decisions made in like the policy space related to how we actually train the next generation of pediatric subspecialists and whether we're positioning ourselves as a greater field of pediatricians and subspecialists to meet the needs of our patients appropriately.
Yeah, that's fantastic. And would you tell us what data sources did pediatrics supply for this issue? Did everyone use the same thing?
Yeah, so the ABP provided demographic and training data for fellows, demographic and certification data for subspecialists, and practice and career data from 7 voluntary surveys that they collected throughout the pediatric workforces, different stages of their career, from residency through each 5-year maintenance of certification cycle.
Oh, wow. So that's pretty robust. Almost a majority of the workforce, right, that they're surveying and putting out here.
It is. I mean, they have collected the most robust data on this because they are the certifying body in the country and inarguably, I think, are the best positioned to interrogate these data and offer the most possible insight in terms of where we're headed as a field.
Wow. Nice. So you've mentioned sort of concerns about people trained to take care of children in a subspecialized way. When you think about the pediatric subspecialty workforce, what niche is pediatric critical care occupying? How is the PICU workforce comparing to the general subspecialty workforce?
Yeah, so we learned some really interesting things, and I would say we in the collective sense across all the subspecialties by participating in this effort. One of the things is that, and I don't think this was a surprise, but it was really valuable to characterize it, is that fields like adolescent medicine, developmental behavioral pediatrics, endocrinology, nephrology, pulmonology are averaging 30 to 50% fewer applicants than positions. Meanwhile, pediatric cardiology, emergency medicine, and then our field of pediatric critical care are routinely filling more than 95% of the available spots, with 20 to 50 more applicants than available positions. And this is all in the backdrop of the number of first-year pediatric subspecialty fellows actually increasing by 147.7% from 2008 to 2022. And many of those spots were actually for PICU trainees. And so PCCM is a 24.2% increase in fellows between 2012 and 2022. And so the state of our field in pediatric critical care medicine actually contrasts to the broader pool of pediatric subspecialists. We are the fastest growing subspecialty. We have the most applicants, and we were able to better characterize that as part of this effort.
Well, that's
Oh, wow.
fascinating. You think about a 24% increase in 10 years. I mean, it's an incredible rate of growth. I imagine this work didn't provide insight into why that might be. Is that correct?
It did. This is really focused on characterizing the supply. And we offer some speculation and estimations as to why that growth has progressed the way that it has over time. But the model itself and the primary focus of the manuscript was to project a trajectory of growth and illuminate opportunities for further study on this topic.
Yes. Thank you. Do we have an idea of how many pediatric intensivists are actually practicing in the United States?
We do. And again, this is thanks to data from the American Board of Pediatrics. So there are 3,689 ever certified subspecialists in the field of pediatric critical care medicine. 85% have maintained their certification. Only 13% are between 60 and 70 years old. And 93% actually of those still working work full-time currently. We've seen some changes in demographics over time in our workforce. There's been a growth in the proportion of pediatric intensivists who are female. We're an increasingly diverse workforce as well. And we were able, again, to characterize that as part of this effort. And it was pretty neat to see, actually, how the field has evolved.
Oh, absolutely.
And you mentioned that 93% of these intensivists work full time. Is there a way to get granular data where a lot of the attendings in my institution, they have research and education obligations? Is there a way to get an idea of how many, full-time clinical FTEs are currently in working?
Yeah, so there's some ability to take a look at that, but there's also a fair amount of controversy about what actually constitutes a full-time equivalent in our space. And one of the things that became apparent to me when I was reviewing the literature in order to write this manuscript was just how fuzzily defined, if you will, that a full-time equivalent actually is for our field. I had the benefit of looking at previous workforce papers as we wrote the current one. And it was pretty striking to see what things looked like only a decade or two ago. The median number of nights, for example, for our workforce used to be 60 median. The median number of nights was 60 per year. And certainly that has declined over time on a per clinician basis, but it's, best we can tell, still pretty variable from site to site in terms of what the actual obligations are and how those are distributed between things like administrative responsibilities, research, clinical obligations. And even within the clinical obligations, we know that pediatric critical care has become increasingly diverse over time with respect to how patient care is actually delivered. And intensivists are involved in a whole bunch of clinical responsibilities now that range from taking care of patients in the ICU to serving as medical command for transport systems to running the hospital rapid response teams to providing sedation, to name a few things, not to mention the folks who are dual board certified in another specialty. And so we have data to coarsely define some of that, but there are a fair amount of spread across the country in terms of how those are implemented site to site.
Oh, absolutely. And that's been one of the joys of this past year, is learning how all the jobs are structured, and then seeing that FTE paper that was also published this year was certainly a treat.
Maybe some foreshadowing to a future episode.
Yes. So when you tell me that broadly, PICU is taking a larger and larger slice of the pediatric subspecialty pie, we've got most of the people who have ever been certified are still working full time. Maybe 13% are 60 to 70 years old. My wheels are already turning in terms of how many people are retiring per year, how many jobs can we reasonably expect to open up per year. But you guys didn't just do that. You did a full microsimulation model. So you can tell us about how you built this microsimulation model for each subspecialty.
Sure. So the first thing I'll say is that it was our authorship team's job to interpret the model, but full credit for developing the model goes to a collaboration between the American Board of Pediatrics Foundation, the Carolina Health Workforce Research Center at UNC-Chapel Hill, and Strategic Modeling and Analysis Limited, which was a company that helped provide some of the modeling services for this work. And so I had the privilege, alongside my co-authors, of interpreting the output of this model, which started in 2020, and with the location and percent clinical time of everyone practicing in a certain subspecialty. And then for each year of the simulation, it added in an expected number of graduating fellows, and it also adjusted the number of practicing subspecialists based on the probability that each physician would leave the workforce, change location, or adjust their percent clinical time. The model was run 100 times to generate mean supply forecasts and associated confidence intervals. And the models were run for each specialty and for different locations within each specialty so that we could look at variations and projections across different geographic regions in the United States. And so that was the foundational bit of information by which we were able to characterize the forecasted supply of pediatric intensivists over the next 2 decades through 2040 in the manuscript.
Nice. So when you think about people entering the field and people leaving the field, how would you broadly describe the supply and the direction of supply of pediatric intensivists in the United States?
So we are on a trajectory for a robust supply of pediatric intensivists. We discuss in the manuscript that this trajectory seems to have been driven by some substantial changes in the way that we have structured our workforce in recent years. And so we know that the field of pediatric intensive care has moved to most locations to a 24/7 in-house model of care delivery. Gone are the days where most programs had attending physicians taking at-home call either for a unit that was staffed by experienced nurses or by trainees, whether they be residents or fellows. Now that's very commonplace that there's an attending physician readily available at all hours of the day in the PICU. And in order to meet this need and this shift in the paradigm of how we operate as intensivists, we saw an increase in fellowship spots. We needed to train more people in order to fulfill this demand. I think what we're seeing is that many units now are fully staffed with respect to that 24/7 staff coverage need, but it's still much more common for a fellowship to open than it is for a fellowship to close. So we continue to train folks based on recent expansion needs in our field, and it's unclear if we are training too many people based on what future demand might actually be now that we've seen some of these big shifts.
I guess, was your model able to show, or through your study, be able to show, like, are there currently more graduating PICU fellows looking for jobs than there are jobs available, or is that something that may come in the coming years?
Yeah, so that was outside of the scope of our current work. We focused strictly on the trajectory of supply of intensivists. There is some literature out there, though, looking at job opportunities in the space of pediatric critical care and pediatric cardiac intensive care. And we cite those manuscripts in the paper, but it wasn't the primary focus. I would say that there are some early warning indicators that the market is more constrained. The job market is more constrained than it was historically for our field. But I also think that there's a lot of opportunity to study this in more depth, to better characterize it, and perhaps shape policy around how we should be developing our workforce moving forward.
Yeah. That's something that I learned when talking to people about the background of this manuscript too, is that in order to start an ACGME accredited pediatric critical care medicine fellowship, you need to have the numbers to make sure that your trainees are well trained, but there's not a governing body that sort of dampens the number of them, is there?
There's not. And I think that you can look at both the advantages and potential disadvantages of that setup. The advantages are that healthcare is delivered regionally, and fellowships in many cases exist in response to regional demand for healthcare needs. And so the ability to open or close a fellowship is left to the market forces that are most relevant to the healthcare institution that's deciding on whether to have a fellowship in the first place. The obvious disadvantage based on how we're discussing this, though, is that there's the potential for things to expand in a way that is no longer sustainable, such that not every graduating pediatric critical care trainee has a breadth of opportunity that might have once been available in terms of job selection. And balancing those sort of competing needs or sets of priorities, there's a lot of complexity, I think, that goes into it. There have been previous commentaries on this notion about how do you find the right balance between centrally controlling, if you will, the number of training spots, but then also recognizing the need for specialties both to self-govern in terms of their training abilities and these needs that may be difficult to forecast. And one of the things that folks have commented on is you want to try and avoid the pendulum effect, which is that you swing too far in either direction, meaning that you are training way too many people and a crisis emerges that people can't get jobs, or that you're training way too few individuals and there's a pressing need for specific areas of patient care that can't be met because there's an inadequate number of subspecialists. And I don't think anyone at this point in time has the exact answer on how to avoid those dramatic swings in the pendulum, except to acknowledge that they do exist. They've existed for other specialties and we've seen them play out. And perhaps better understanding the trajectory of supply of our workforce will help us to mitigate the chances that we're going to see dramatic swings of the pendulum in our own field.
Chris, it's a fascinating conversation thinking about how does one subspecialty regulate itself into training only the appropriate number of physicians to take care of the patients that they anticipate will be coming. Outside of pediatrics, are you aware if this has been done in other like internal medicine subspecialties or surgical subspecialties? Has there ever been a somewhat of a top-down approach to a subspecialty limiting growth or cutting back?
Oh, that's a good question. I have to say that I don't know. What I would offer, though, in place is that we do have some experiences a little more proximate to our field that we should draw from as we think about how to move forward. And so, one would be that there is a body of literature out there about our colleagues in the pediatric oncology space who have documented that they have been for a period of time oversubscribed, meaning that there have been more trainees entering than the market is prepared to absorb from a job opportunity standpoint. And, I think the old saying is that you get 2 out of the 3 when you choose your job. You can get the job that you want, the location that you want, the compensation that you want. And I think when we've seen fields become oversubscribed, folks have been lucky to get 1 of the 3 as they've selected their starting positions to build a career around. Contrasting example might be pediatric anesthesiology, which offered some forewarning in its literature several years ago about the potential for oversubscription. And when you talk to folks in that space, there's some sense actually that maybe they overcorrected in the opposite direction too much, and that they've been underfilling positions in pediatric anesthesiology, that there are plenty of jobs and not enough graduating trainees. And when I was discussing our workforce manuscript findings, actually, when I was giving a grand rounds in a department of anesthesiology, I was asked by several pediatric anesthesiologists just to be careful about how we as a field interpret the data that we're putting forward, because the pendulum, again, can swing both ways. And we want to be mindful about overcorrecting if we're going to take action based on the supply projections that we offered.
Oh, absolutely. And I also do want to state a lot of people listening to this podcast are making important decisions about their career, and the perspective you're offering about the job market beyond the fellowship match is important to highlight and maybe not use in isolation. Because as a pediatric resident applying for critical care fellowship, the top of your mind is that 20 to 50 people are not going to be able to get a fellowship spot every year. And it's hard to see that as not even the primary bottleneck for the ability to practice in the field, that you could give 3 years of your 30s to this fellowship and not have those opportunities to practice.
Absolutely. And I think more than anything, what it encourages are some really candid conversations that people should be having as they select their career. The choice to become a pediatric intensivist, I think, is a deeply personal one, and these data should really just be one bit of information that decision is based on. But I would say that it's an important bit of information to take in consideration, especially perhaps if you're deciding between an alternative field or feel torn between a few different potential career trajectories. These may have some important weight that's added to the scales of the decision-making process. In that regard, I think it's actually quite useful for trainees to bear in mind as they are thinking about how they're going to embark on a subspecialty career.
Chris, earlier in our conversation, you mentioned that, graduating trainees seeking that first job, they're looking to get the practice type, the compensation, and the location, the trifecta, so to speak. And sometimes you miss on one or maybe even 2 of those. In your paper, you had an interesting analysis of the expected, perhaps, physician excess based on different regions of the United States. I'd love to get more comments on that.
So what I could say about the geographic distribution of intensivists is that, not surprisingly, we saw a fair concentration around the more metropolitan areas, and that there's a relative sparsity of intensivists for more rural regions of the country. But we're seeing population growth through all of those spaces. And so I think there are, opportunities as you look at the United States as a whole, where there's currently a relative paucity of intensivists that are likely to need intensivists increasingly in the coming years. And so while some areas may be saturated, I think that we're going to see other areas of the United States better represented with pediatric intensivists moving forward.
Excellent. Well, I have to tell you that right after you published your paper, I had a meeting with a lovely division chief in Las Vegas, and she said, "You're from New York. Why are we talking?" And I said, in the Southwest region, I hear that I may be able to fill a clinical demand. She's built a really wonderful children's hospital down there.
Nice. Your anecdote is spot on in that if you're pulled into this field because of a strong desire to take care of critically ill children, which really needs to be at the forefront of the desire to become a pediatric intensivist, then the opportunities just may be in some exciting spots in the United States moving forward, which I think is there's a lot of good things. As I mentioned earlier, I moved around a lot when I was growing up because we had to move from mine to mine, and I was able to have some great experiences as a result of it.
Well, Chris, thank you so much for the hard work you've done for this manuscript and giving us this information. We thank you for sharing your time with us and wrestling with some of these difficult concepts. I wanted to open it up to you for one last open-ended question. Anything else that you'd like to mention or reinforce or leave a final message with our audience today?
Yeah, I think it's important to remember that the supply information is just one bit of information that should inform big decisions that are made in this space, whether they're made by the individual who's choosing a career or whether they're used to guide the development of policy. And it's a model, and we're trying to predict the future. And predicting the future is hard at best and possible in many cases. And so I think that we were able to come up with some insights that are going to be really important for guiding future work in this space and honing how we continue to craft our field moving forward. I think that there is every opportunity to look at the data optimistically. PICUs have grown. There are more PICU beds at major children's hospitals than there have ever been before. We're seeing healthcare delivered in much more novel ways. We're seeing the intensivist role develop over time to cover a lot of different clinical care spaces than it was originally designed to cover. And I think that there will continue to be a natural evolution and that there will always be a spot for the type of dedicated, idealistic, typically very bright individual who is drawn to the field of pediatric critical care. And so I think there's always going to be opportunity for our field. And it's one of the things that I think is, besides providing patient care, the best thing about being a pediatric intensivist are the people that you get to work around. I think our future is bright as a field no matter what, but this is hopefully going to help us better prepare for the challenges that I think every field faces.
Oh, well, that's beautiful. Dr. Chris Horvat, thank you so much for joining us today.
Yeah, thank you. This is great.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening. Yeah, sorry, this conversation is kind of negative. We need a positive question to finish. Be like,
Yeah, no worries.
Yeah, thinking inspirational things.
Ask you for your favorite multi-centered database.
Yeah, that's right.
I think it might find some listeners excited.
You know.
That's right.
Yes.